with you. Are all of our contributors, our formal contributors, on the call yet for the schedule for this hour? I've seen some of the names. Obviously I've seen Anne O'Reilly.
Yes.
Just have a quick look through Seamus and check.
Yeah. So I've seen Anne. I've seen Tom.
See Mark on.
Yes. I haven't seen Bernie McCafferty. Is Bernie, you on with us?
Yep, she is.
Okay.
Deborah's on.
Okay.
Yeah, we're ready to go.
That's great, everybody. Well, look, thank you very much. So this is a really important session for our trust today. We're here to talk to you about a really important program. It's called the No More Silos program of work. And this is our first opportunity to have a very widespread engagement on the program and how it's shaping up and how, more importantly, you can influence it. So I just want to kick the session off today. My name's Teresa Malloy. I'm the Director of Performance and Service Improvement in the Trust. I have a formal responsibility for promoting involvement in the development of all of our services. And I know that I know some of the names of the people who are on the Zoom call today, and some of you really I don't need to talk to you about what is involvement, but I'm conscious we may have new people who have come to us and started to engage with us, particularly on this programme. So really how we see involvement within the Trust and within this programme is really an opportunity for us to hear the voices of people who either have used or will use these services or whose families have used these services. And the whole intent of the work that we do with involvement is in order to improve or make services better. In terms of the Trust itself, really the context that we have is that we talk about our 4 ambitions in the Trust. And they're really all around the life course. So we want to make the geography of the Western Trust and the people that we serve, we want this to make this a great place to start life, to live our lives well and healthily, to grow older. And we also wanted to make it, for all of our employees, a great place to work. So it's important because we want to improve services, and we want to improve them in all sorts of ways by listening to and engaging with the people who use our services, however wide that circle goes. It's really important to listen carefully so that we can use resources effectively and that we can give power and influence to service users and carers to contribute to and to influence the work. So as far as we're concerned, we want to use the expertise and the experience that you have and our service users have and their wide circle of family and carers to influence how we do our work, how we go about our work, and to make sure that we understand really clearly what matters to you. We have some formal structures within the Trust. We have a new Improvement Through Involvement Committee that is chaired by a non-executive director, and it was established during this year very formally, and we have an integrated involvement plan. And if anyone on the call today wants to learn a little bit more about the ways that we work, and in particular look at our integrated involvement plan, please don't hesitate to contact Seamus or Brona after the Zoom call today. So why today is important to us, really, we want to use today, and it's only a short session, only an hour, so we have to use it very purposefully. We want to use it to inform all of you about the programme and the developments on No More Silos. We want to engage with you, and we want to offer opportunities for you to help us to support this really important programme of work. I'm going to conclude now. We have a very short time. We have about an hour for the webinar. I'm going to hand over to Seamus, who's really our MC and our facilitator for today. I suppose I see this as a start of a process. We've been engaging, obviously, so far in this programme, both locally and regionally. But we see this as a powerful vehicle to get more people involved in our work and have you influence the direction that it takes. So the strapline for this is working together under this programme, and we hope you will help us do that. Seamus, I'm going to hand over to you now for the facilitation for this hour.
Okay, Teresa, thank you so much for your presentation and for agreeing to chair today. And for those that don't know me, my name's Seamus Ward. I'm the Head of Health Improvement, Equality and Involvement in the Western Trust. It's a bit of a mouthful, but today I'm just going to be the facilitator or the MC. I'm just going to try and keep things moving smoothly as we work throughout the hour. I just want to remind everybody that the session has been recorded. And we're recording the session for affiliation purposes, and also as well too that we can share this with representative groups who may not be able to attend today or may not be able to attend in this format. So that's the reason that we're recording the session. Today we're going to hear from 5 speakers on the No More Silos work, particularly on the No More Silos work. We're going to hear from the Trust Director, Geraldine McKay, and also across the 4 work streams, the 4 leads. We're also then going to hear from Anne O'Reilly, who's been the Service User Rep in the Local Implementation Group. After we've heard from those speakers, there's going to be an opportunity for a Q&A session. So if I can remind everybody, I see it's operational already, but we have a chat box function. It will be open and we're welcoming questions or comments from anybody throughout the session. And as I say, look, we'll move then to a Q&A session where we can only facilitate about 5 questions, but we're going to ensure everybody that any questions or comments that are raised through the chat box, we're going to respond to them within the evaluation template that we produce at the end of the program. So if your question doesn't get asked this time, we will do our best to ensure that the question is responded to within that final evaluation. After our Q&A session, then we're going to hear from Brona McMonagle, who's our involvement manager. And Brona's going to talk us over the opportunities to be involved in the No More Silos work and our involvement plan for this piece of work. We're going to do a wee Zoom evaluation, so hopefully everybody can stay until we've got to that. And then finally, our chair, Teresa Malloy, is going to do a final summary for us and close. So that's just talking over our session for today. So I'm going to try and move swiftly on to the important piece. I'm going to remind our speakers that we've got 5 minutes or to do our best to try and get the information through within that time scale. Whenever you are invited to speak, if I could remind you just to unmute your mic before you start your presentations. So without further ado, if I could first invite Geraldine McKay, Director of Acute Services, to present on the No More Silo structure. Thank you, Geraldine.
Thank you, Seamus. And just for everyone's benefit, I have Dr. Kieran Mullen with me today, and we're going to do a double up. So Kieran's going to cover the first 3 slides, and then I'll complete the second 2. So Kieran, I'll hand over to you just to get on with it, saying we have only 5 minutes.
Okay, Geraldine, thanks very much. Clock is ticking. So just basically, folks, to try and set the scene here, No More Silos is essentially an initiative that's been developed towards the end of last year, really with the aim of ensuring that we maintain and improve access to our urgent and emergency care. This would have been a great idea pre-COVID. It's even more pertinent now in COVID times that we make sure that where patients are being brought to healthcare facilities for urgent or emergency care, that they are done so safely, that they're brought to the right place, and that we're protecting staff as well. So this was launched by the Minister back in August 2020, and a No More Silos regional network was then set up to oversee the delivery of this. Next slide. So essentially, the No More Silos has been broken down into a set of 10 regional actions, and they're set out on this slide. You can see on the left, we have a regional network, No More Silos Network, and LIG stands for the Local Implementation Group, and that is essentially where we have the Western Implementation Group to basically feed in to the No More Silos work, giving it the local flavour and how we will make it work in the Western area. And obviously then it has overlap with staff in our community and our hospital care, both with GPs, other healthcare professionals and trust staff. Now, I'm not going to go through the detail of each of the regional actions because the rest of the presentations will be going through how we're going to aim to deliver on the 10 key regional actions. And then obviously on the right-hand side is the enablers to allow us to help deliver that. Next slide, please. So just to give a set out of the Local Implementation Group, as Geraldine has said, I co-chair this group with Geraldine, and we have fortnightly meetings, and we have set up 4 work streams to basically aim to meet the 10 key actions from the action plan that I've just mentioned in the previous slide. Each work stream is made up with leaders both within our trust community and also within our community and general practice. And obviously then we rely on a lot of people behind the scenes to support us in that work. So next slide, then just hand over to you, Geraldine, to maybe go through some of the details of the work streams.
Okay, so the easiest way for us to present this quickly was to present our plan on a page. So the plan on a page identifies to the right the membership of the group. It also sets out the structure and the links to the regional implementation group. The co-chairs, as Kieran has said, is myself and him. And I suppose what I want to say about this is it reflects the importance of this programme of work to colleagues both in primary and secondary care, and we need to get pathways right for our unscheduled patients. The detail of the 4 key work streams are there, and this afternoon you will hear from the work stream leads regarding the progress they have made to date. The key enablers to support the work streams are across the bottom. So you have innovation, and this is led by Dr. Aaron Peace, I suppose because of his role as well as Chief Executive of CTRIC around innovation. And in terms of the second key enabler for us, it's about communicating. And we have a communication plan. We make sure the message gets out to the public, our population, our clinicians, our staff at frontline level. And we have incorporated a member of the communications plan into our fortnightly meetings. Okay, next slide, Seamus. So progress to date, I'm not going to go into any detail because you'll hear all that, but I just want to say 2 things. I could summarize the 10 key actions in the following way. Actions 1, 5 and 8 are about how I, as a member of the public, will access services. Actions 6, 7, 9 and 10 are around how I, as a member of the public, will receive care, where I might receive care. Is it at home? Is it in the hospital? Is it in another community facility? And I suppose the whole purpose of this, as Kieran has said, is to try and redirect patients from attending our EDs and taking some of the pressure off. Ambulatory care and rapid access to specialties you'll hear about, and that is around access for our GP colleagues into directly into the consultant level advice at the front door. The 24-hour telephone triage up and running now, and you'll hear about that. We have specially specific hubs that patients can access through cardiology, respiratory. The ambulance turnaround is a key action because of some of the pressures that you'll have read about, where ambulances have been queued outside some of our acute hospitals. Fortunately, we don't have that problem in the West. Very rarely, if ever, we have to allow ambulances to queue outside our departments. However, in planning the implementation of this action, we have realigned our ED. We have a new waiting area, and we are about at the end of March to open a specific area for an ambulance offload area for patients. So I suppose we are meeting that as well. And you'll also hear this afternoon from the community infrastructure required and the progress to date around acute care at home, hospital at home, and patient flow and hospital discharge. Thank you.
Geraldine and Kieran, thank you so much for that global update on the No More Silos work. Now we're moving on to work stream 1, and we've got Dr. Kieran Mullen-Stull and Dr. Tom Martin, who are going to give us an update on the rapid access to specialty assessment and treatment.
Yeah, thanks very much, Seamus. It's great to be able to go through this. So to give it a little bit of background in terms of why this is needed, you know, if a patient goes up and sees their GP and needs hospital input, traditionally the pathways that could be followed would be an outpatient referral or sent up to the emergency department as an emergency. But over the last number of years, we've become increasingly aware that there's a fairly sizable group in the middle that aren't safe to wait for outpatients and don't really need to be sitting in an emergency department because they don't need immediate emergency care from the emergency doctors. Now, if the GPs are in that position and they have those 2 options and they're a bit worried, the safest option has traditionally been to send patients to ED, and that has led to congestion in ED and long waits for patients that are probably unnecessary. Often the GP will know before they've seen or after they've assessed the patient, that the emergency department probably won't be able to sort out this patient themselves, and will need to refer on to another team, possibly the inpatient medical team like mine, or a specialist, a subspecialty like a chest specialist or a GI specialist. And this workstream really focuses on cutting out the middleman and allowing the GP to have access direct to the doctor that's going to be able to sort out the problem for that patient. So there's 3 main streams to this. The first stream is ambulatory care or same-day emergency care, where if the GP has a patient who is at risk of needing admission to hospital in the near future, they're able to access a hospital consultant who then has access to all the scans and whatever resources the hospital has at its disposal, but that wouldn't be available in the community. And they can bring the patient direct up to an assessment bed, use those resources as efficiently as possible, and try and get the patient sorted out the same day, and ideally get them home where the vast majority of patients would rather be, rather than admitting them to hospital. We've had that service set up for about 3 years here in Altnagelvin, and it has been running reasonably well. COVID has affected it, and it has been cut back due to that recently. But we're working on getting that up and running again, and even expanding on that model to make sure that there's always capacity, and no patient will be sent to the emergency department that is more suitable to come directly to the ambulatory care unit. The second group of patients we're focusing on is when a GP sees a patient in the community, and it's very obvious to them that they are going to need to spend a night or 2 in hospital. And currently the pathway for those patients is they're sent to the emergency department and worked up from there as well. Now, if they're unstable and need resuscitation, that is the correct pathway. But often these patients don't need that sort of care, and in that circumstance, then they're much better being sent straight to the bed that they're going to end up in anyway, or an associated bed, and not being kept in the emergency department with the emergencies, and again, contributing to the congestion and being in a more unpleasant, potentially more unpleasant environment. So we're hoping to get some beds ring fenced for that purpose in the very near future, and that will be one of the prime objectives of Workstream 1. We're well on our way to getting that arranged, I hope. The final stream, or the final aspect to Workstream 1, is direct access to a specialist, as not a hospital doctor like myself, a general hospital doctor, but a subspecialty person like a respiratory doctor or a cardiologist, or one of those people that we do need sometimes whenever you've got a particular problem. And we have been working on pathways to open those options up, both to me as a hospital doctor and to the GPs as well. We've had some success with developing cardiology hubs. The respiratory team have started some ambulatory work and are expanding. The rheumatology team have opened up, have assessment space as well, and we're working hard on getting that arranged for all specialties that we need to. That's me finished, thanks.
And just to come on the back of Tim, this piece of work is ideal for No More Silos in terms of it challenges the notion that the only way into a hospital is through the emergency department. And we've been very fortunate in the West, and as Tim has outlined, that this model has already been in place, and we're now in a position, or we're hopefully in a position, to try and enhance that ambulatory care access because of all the interaction that happens already with GPs, and where GPs can link in with the likes of Tim and colleagues, where basically a patient can access a specialty or same-day treatment to allow discharge. This fits the whole No More Silos ethos. So as I say, Tim's work to date has been it's been very well received already, pre-COVID and pre-No More Silos. COVID has put challenges on this, but we're now hopefully in a position with this piece of work to enhance it further.
Thank you very much, Tim, and thank you very much, Kieran. Okay, we'll move swiftly on to Workstream 2, which is scheduling unscheduled care, and our speakers are Mark Gillespie and Deborah Ward.
Okay, thanks for the opportunity to come along just to talk about Phone First. And I suppose I've been involved in the No More Silos work from the start within the Trust, and believe that we need to offer alternative approaches to patients to access healthcare, particularly in the challenging times that we find ourselves in. And I suppose Phone First in itself offers patients the opportunity to get directed to the right care at the appropriate time and at the outset of their journey, but also to avoid those busy waiting rooms, which we know can be quite challenging for everyone. We are now in week 3 of operation of No More Silos, and the service itself is a telephone first service, as you can imagine from the name. Operates 8 a.m. to 12 midnight, 7 days a week, and is a partnership approach between ourselves, local GPs, Western Urgent Care, and the Health and Social Care Board. And I suppose Western Urgent Care play a key role in this. For those of you who are on the call, Western Urgent Care support our out-of-hours service and employ a number of nurses who are experienced in terms of dealing and directing patients to the appropriate care. And we are really focusing on patients who, including children who are feeling unwell or who have an illness or injury, which requires urgent treatment, which is not life-threatening. And really, when you make that call, you will have that call answered by an experienced nurse. And presently, you will have one of a number of outcomes. One will be self-care and advice. The second will be direction onto out of hours. The third will be redirection back to your GP or back to a pharmacist potentially, because community pharmacy is an area that we know that is underutilized as we move forward. And as I said, self-care advice. I think one of the things that we've learned very quickly, and we talked about it earlier on with Kieran and the wider team, is that there's significant potential for additional pathways to come on stream fairly quickly. I think I as a member of the Western Trust for a number of years, I think we pride ourselves in terms of being ahead of the curve in some of the areas that we work in, just like Tim and Kieran earlier on explained around ambulatory care. But we have other direct assessment pathways which we already have engaged with the clinicians on to expand the service fairly quickly. Some of the areas that we're currently exploring are around fetal assessment in early pregnancy, because a waiting room in an A&E department is not often the appropriate environment for those people to be coming to in the first instance if we can direct them directly to the care. The second piece is cardiology and the cardiology hub. We're working very closely with Paul McGlinchey, our clinical lead, who has been the key architect of that service, and really linking those low-risk cardiology patients direct to the speciality from that telephone service. The third thing that we're working on very closely with our ophthalmology colleagues is around those patients, again, with ophthalmology problems that aren't suitable to a waiting area. And the fourth thing is around some of the more vulnerable people in the community who are homeless, working alongside the podiatry team as well. So in the first week, in the first and second week, we've had upwards of around 400 people who've accessed that service. 15% of the population who make that call go on to self-care with advice, and 15% have gone back to GPs. I think one of the key enablers in this is the engagement from the GPs in terms of that two-way process, and I think we can all recognise that benefit from that. I think the other piece that we want to tell people about as well too is that we do believe that there are certain elements of unscheduled care that we can actually schedule, particularly from a minor injury perspective. And I think we've had really good engagements from Southwest Acute, from Omagh Primary Healthcare Centre, and from Altnagalvin as well. And what we've been doing is when somebody phones up with an injury, rather than having to come book in the waiting room, we're actually booking them directly to that appointment and that scheduled appointment. I think Dee's on the call, and I have to say Western Urgent Care have been fantastic, and I know we made that point earlier on, Kieran, at our meeting. They've been fantastic at stepping up to the plate and really moving on this without delay. They've been really key to this. But I think some of the learning already is that the early morning appointments that we have out for scheduling maybe need to be moved forward to the back end of the day. So we really have been engaging in the feedback that we've been receiving from the departments and some of the members of the general public as well. So we've still some more work to do on the comms piece with the GPs in terms of what the line is for and feeding back. But I think the early signs would lead us and indicate us to say that there is definite value, number one, in phone first, and the scheduling piece to try and avoid those long and lengthy waits in the waiting room. We have a project board, and I know Anna Riley hasn't been able to join some of the meetings so far, but certainly has contributed, I know, to some of the other meetings in terms of some of the feedback. We meet weekly, and we do believe that we will be able to bring these pathways on stream and bring them on stream fairly quickly to make that experience, I suppose, better for that population of the Western Trust. So that's a short synopsis, Teresa, I think, and Seamus, of where we are at this point in time.
That's great, Mark. Thank you. And obviously, Bruno gave us a wee bit more update as well too, and opportunities to get involved with the project boards. Deborah, I'm wondering, is there anything quick you want to add just to Mark's, just cautious of time, but is there anything else you would just want to add to his update?
No, hello everyone. Mark's just covered everything there, just in terms of the opportunities this project's provided between Western Urgent Care and the Trust itself, in terms of obviously going back to Teresa's point about opportunities for working together and removing those silos. We obviously provide the GP out of our service, but we've been able to use our infrastructure for IT, for software, for nurses, telephones, and everything like that we wouldn't normally use during the day, but we've been able to actually apply them to the Trust's benefit for this. So for us, that's something really to be proud of, actually. But everything is moving with pace. It's only been 2 weeks. I think actually, just looking at the numbers, we've had about 750 calls since the project was up and running. But what we're doing is every couple of days there's a different meeting. Myself and Mark touch base either with the different companies or the different departments, and we're just keeping things going and learning as we go through and trying to flex and everything and change everything as we keep going. What we learn, what sort of pathways do we need, what's the patients coming through, what's their complaints and conditions and ailments about, and actually what's the other ways that we can divert those patients safely away from the ED. From our perspective as well, when the nurses are speaking to the patients, a lot of them have reported that they really appreciate the opportunity of actually booking an appointment for different reasons and whatever their own situation is. Obviously, in the circumstances around now, people don't want to be putting themselves into areas or positions where they might be exposing themselves to other people with the virus and that. But even just for planning for childcare, people have been able to appreciate the opportunity that if they phoned at whatever time in the morning, they knew they had an appointment in the afternoon. And for them as well, it was that reassurance that something was going to happen today. So that feedback from the patients to the nurses has gone down well as well.
Great, Deborah. Super. Thanks a lot. Okay, we're going to move on swiftly now to work stream 3. I was looking forward to this. One's a bit of a tongue tangler. Anticipatory care enhanced framework for clinical and medical input to care homes. So I'm going to hand over to Bernie McCafferty and Dr. Monica Monaghan for update on this workstream.
Thanks, Seamus. Good afternoon, everyone. Seamus, this is a bit of a tongue twister, this one, but really this relates to the where that Geraldine referred to earlier. So really this covers the key actions 6, 7 and 9 from the regional work plan. So 6 is anticipated care planning, 7 is about acute care at home and hospital at home, and 9 is about additional and enhanced support that we would like to provide to our care homes. And this work stream is led by, I think Stephen Todd's on there, and Stephen's a geriatrician in Altmegalvin, and by Dr. Laura McDonald, who's a GP in Fermanagh. So very quickly, each of those key actions around an anticipatory care plan is really where, working with the GP and the trust, we would like to support our patients in care homes, support and involve them to understand what their wishes are and what their care priorities would be should you become well. So it's about where you would like to receive that care when you are unwell, and maybe hospital isn't always the right choice for you. Can we support you to remain in your own home? And can we support you to remain in your care home without always having to move you to hospital? And finally, really, it is also about end-of-life care support that we can provide to all of our population when they're at that stage. So really, in a nutshell, that is what anticipated care plans are about. And next, I would like to move on, Seamus, to really the how we're going to do it in the community, and the how is around acute care at home and hospital at home. And Seamus, I'm going to spring it on you. Deborah McDade, I think, is on the call. And Deborah is our sister in acute care at home here in the northern sector. And I think Deborah is probably better placed than me to speak for a short time on that service there. And then Dr. Monaghan will speak on the hospital at home service in the southern sector.
No bother, Bernie. If Deirdre wants to unmute, yeah.
Bernie, this is not Deborah, this is Stephen Todd. I think Deborah has a microphone.
Sorry, Stephen.
Malfunction, no problem. So you said I'm a geriatrician, doctor specialising in the care of older people. Our acute care at home service has been up and running in the northern sector of the trust for about 4.5 years now. Acute care at home, that's the Northern Ireland term for hospital at home services. So several of the other trusts have similar services running. And as it says on the tin, basically we bring the hospital to the person rather than the person having to go to hospital when they're at a stage where the GP, their GP would feel that they need hospital specialist treatment. So we're treating conditions like chest infections, urinary infections, heart failure or dehydration, and we can give people intravenous injections of antibiotics, fluid medication, we can provide oxygen and things like that. As well, as a care of the elderly team in the hospital, we have specialist pharmacists, physiotherapists and occupational therapists as part of the team, so we can undertake those functional assessments as well in the person's own home and provide appropriate additional support and onward referrals. So as I say, it's a very valued service from the feedback we get from patients and families and from local GPs for the over 2,000 people who've been treated by the service so far. Currently, we're trying to expand the service later into the evenings and also take new referrals at the weekend, and we're recruiting for those posts right at the present time.
Okay, Stephen, thank you for joining us. Bernie, Dr. Monica Monaghan, are we going to hear from you now as well too? Yeah. Okay, thank you.
Yes, I'm happy to talk. So I am a jobbing cardiologist by trade. But throughout the COVID crisis, I've had an increased role in hospital flow and safe and discharging patients from hospital safely and in perhaps a more aggressive manner. And rather than seeing this as a challenge, I've seen it as an opportunity. And I'm very grateful to Stephen Todd for the leadership that he has given to us as a small meeting began at the beginning of December about how the southern sector had yet to develop an acute care at home or a hospital at home type model. And I saw the opportunity, and with a team of people, and I have to say that the incredible buy-in across the trust, I've been in the trust now for just over 5 years, and incredibly impressed with the teamwork across the northern and southern sector, how we're working together to make this happen. So we took on the rapid response nursing team, came under our umbrella. Bob Brown from PCOP and Michelle McKinley bought in, and we had help from the Drumclay rehabilitation service. And we started with one worker bee, if you like, junior doctor on the ground and myself. But I recognize, although I care for patients very often with complex cardiac conditions from the age of 14 to 105, which was my latest pacemaker, I also care for lower respiratory tract infections and the complications of type 2 diabetes and urinary tract infections. So I felt confident to give some leadership to that role. And with the incredible support of Carmel Darcy, our care of the elderly pharmacist, we started this process. And like Stephen says, we've had a lot of positive feedback. What I have seen most, and the most vision that I've got from hospital at home or acute care at home, is really that it's no more silos and it's Pathfinder by another name. And that's really what this slide is about. And this is what our vision of healthcare going forward in keeping with No More Silos. So as Tim said, it's about how do patients access everything that we have to offer. And I don't mean just medical, I don't mean just physical. So I mean mental health, I mean allied health professional. We have digital platforms now for self-care. I don't have to, a patient doesn't have to come to from Rosslea now for me to assess them cardiologically. We can do that on virtual platforms. So we're looking at an entry pathway, and at the top, we've got phone first. And I think that's something that we will use as well to access the multidisciplinary team that will be led by nurses, doctors, pharmacy. We can take patients from the emergency department, from general practice, from medical assessment units, and from outpatient clinics. Hospital at home does not require that layer of GPs to currently assess the patients. We will take direct calls from the nurses and the nurse managers in homes, but we will communicate frequently and early with our GP colleagues for patient safety and continuity of care. We will develop a hub with satellites where the assessment will be carried out by senior nurses and consultants who are specialising in the common presentations to emergency departments, and that includes psychiatric liaison, and we've got buy-in from Dr. Diana Cody, diabetes, respiratory, cardiology, and we will offer investigations in the form of cardiac, respiratory, etc. And then we will signpost our patients to the onward health journey, and that might be treatment, pharmacist, primary prevention programs like our Hearts, Our Minds, frailty assessments to keep patients safe in their own homes, like OPALS, OT, physio, smoking cessation, or we might signpost to community services. So they will come back maybe to hospital at home, the community respiratory team. And we can't forget that the massive role that the voluntary groups offer as well. And we need to bring them on board with all our expertise. And I suppose my two main things that I think about are, one, patient safety and dignity, and where the right patient should be treated at the right time. And the second one is, I am the daughter of a Fermanagh man, so I always think about value for money. And I think about going forward that this is the model for patient safety, but for also streamlining in a time where we are thinking about financial constraints. So thank you for listening.
Thank you so much, Dr. Monica Monaghan. Okay, so we're going to move on swiftly now to work stream 4. So we've got Dr. Roisin Healy, and again, we've got Bernie McCafferty. Okay.
Seamus, not to force your time or anything, but there was a bit in work stream 3 around supporting our care homes that I just wanted to mention. It's the final part, it's key action 9. So this is where we really want, I suppose the current climate has demonstrated to us that some of our most vulnerable clients are within our care homes. And we just wanted to make people aware that it is our intention to provide enhanced support to our care homes, be they a nursing home or a residential home. And we would like to develop a dedicated trust support team to work with the GP and the care home staff to provide that extra care and support for those residents within those care homes. Sorry, that was just the last thing on that, Seamus. Thank you.
No, thank you, Bernie. So over to yourself now, and Dr. Roisin Healy for workstream 4.
Just by way of introduction, Seamus, this really covers, it's another part of the where, but the where this time really is the hospital, and the patient flow in hospital discharges. If you're in a hospital, is how is your stay in hospital, and how can we help you on your journey home? So how's your hospital discharge? Can we plan for it? Can we get you home as safely and as quickly as possible? Be that to your own home or to a care home or home with some other support. So this work stream is led by Dr. Neil Black, an acute consultant in Altnagalvin, and Roisin Healy there, a geriatrician in Altnagalvin as well. And Dervla McManus is also our GP colleague involved in the group as well. So one of the key actions within the this work stream is around frailty, and Roisin Healy is going to speak a wee bit about frailty and the frailty pathway.
Thanks. As Bernie said, this workstream really got to do with frail older people and where's the best place to care for them and giving them options outside of presenting to emergency departments in an acute crisis, which is where a lot of older people end up at the minute. Obviously, this is a bit of an overlap with other work streams. There already are options in the trusts with regards to acute care at home and hospital at home. And this is work stream really has a bit of overlap with work stream 1, in that one of the things that we want to look at setting up is a frailty unit for older people. So frail older people may be presenting with things like increase in confusion or falls, giving them an option other than the emergency department or acute care at home, where they maybe need to come up to hospital for assessment by the doctor and the MDT, and maybe need some investigations that can only be provided in hospital. And the idea would be that if people were assessed there, they could maybe be forwarded on to have their ongoing care in our other already existing pathways, maybe being discharged to acute care at home or straight to a rehab ward in the Waterside Hospital, you know, just avoiding the emergency department and the need for another move for patients. One of the other things that we're looking at in this work stream is patients with delirium. So people who present with confusion out of keeping with their normal aren't always ideally suited to being in a hospital environment, and sometimes they can end up being in hospital for a long time, and it's looking for other options for them. I suppose with regards to both of those things, we're a little bit further, a bit earlier on in the process than some of these other work streams at the minute, whereas we're very much in the early planning stages at looking at alternatives for patients with delirium and patients for frailty. But we are meeting as a group to talk about the options moving forward. So earlier days really for work stream 4, but work going on how we can support people to get out of hospital quicker and other options for frailer older people in particular.
Thank you, Dr. Healy. Bernie, I'm wondering, is there anything else you want to follow up on work stream 4?
Just lastly, Seamus, as Roisin touched on, just the other aspects of this work stream is around support for those with delirium, both outside of the hospital and their journey through the hospital. There's working on around those presenting with mental health conditions at the hospital and enhanced liaison support, and then providing care support for people in their own home, enhancing our care home capacity to making sure that we've got the right, is it a nursing home bed, is it a dementia bed, or is it a residential bed, to make sure that our stock is delivering what it is that we need to deliver. And then we want to work in partnership with other two providers to support the journey home from hospital. And really that's it in work stream 4, Seamus. Thank you.
Thanks a lot, Bernie. So look, we're going to move on to our last speaker today and the No More Silos work. I just remind everybody that we still have the chat box open. I see it's quite active. We mightn't have any questions to answer whenever we finish off, but just to remind people to keep putting the questions on, because we will try and follow up afterwards as well too. I suppose from our point of view and those that are involved in involvement, this is a really, really important presentation. We have Anne O'Reilly, who's the service user representative on our local implementation group. So Anne, over to yourself.
Okay, thanks very much, Seamus. Can I just start with the premise that I sit as a care lens in all of the groups that I sit on, and that there is something that I'm reminded all of the time, that service users should be present, powerful, and at all levels in the organisation as an essential asset in monitoring the quality and safety of services. So in many ways, that's where I start, and that's where I start as the chair of the Unscheduled Care Reference Group. I'm not here in any formal capacity. I'm here because I care about the role of carers and service users being involved in this process. I'm sure those that are listening do appreciate it's a complicated process, and it's one that can sometimes be hard to understand. So don't worry if it feels complicated, you do get there. In relation to the next slide, just to mention, we have representation as service users and carers at all levels at the network regionally, as well as we represent service user and care on all of the local implementation groups across all the trusts. But there's a big ask today to grow that involvement. There's 12 of us at the moment. We've been there for quite a while, but the voice of service users and carers and the commitment of the Western Trust to increase that is there. We have a comprehensive involvement plan, so we know what we want to do, we know how we want to do it, and we have a strong group in place to help us. I have to say that all that you have heard to date has already come from information from the patient experience and involvement work that's been done, and I'll talk a wee bit about that. But as a starter, I would have to say, sitting on the groups and the professionals that you've heard about today, there's a couple of things that have really struck me as success indicators already. The strengthened relationship between primary care, the GPs, secondary care, hospital care, has been one of the greatest strengths of No More Silos, in my view, to date. And it shows in the professionalism, the teamwork, the will to do things differently across primary and secondary care, and that is good for the patient. You have already heard there's been a strong focus on access, on navigation. How do we go through a complicated system as a patient or a service user, and how we are coordinated through that complicated system. Care homes have been brought in from the cold. COVID has brought care homes right into the centre of things. That was missing, and I'm really pleased to see it in there. And we are now giving more weight and equal weighting to the importance of how we're admitted to hospital, how we go through the hospital, and how we're discharged from hospital in whatever way we enter the system. So it's good to see that going on. So next slide. There has been patient service user care feedback to date, and it's important to say. So this has not come out of the air in a way. There was 1,536 patient surveys done in emergency departments. There was feedback on engagement. We had an engagement exercise in OMA when we were talking about urgent and emergency care before we moved into No More Silos. And then we looked at what the literature and what service users were already telling us. So there'll be no surprises here. It's about improved access, information, communication, navigation to overcome the confusion. And that includes communication among professionals, single point of access. You've heard about Phone First, 700 calls. It's a very important development, and a directory of information. Timely access, direct and timely access for the most appropriate service, and that there's consistency and standardization, and that you improve the whole patient journey, you improve waiting times at ED. The big one that is coming through is to increase awareness and confidence in the alternative services. There will be services coming out of No More Silos that will be different to what we're used to, and we'll need to be communicated about it, we'll need to be told about it, we'll need to understand it, that knowledge to use gap with clear public messages. Next slide. The other thing to mention is when we looked at what was driving patients and individuals to ED was the patient experience of primary care. The difficulty sometimes to get through at daytime and out of hours access, and 35% of referrals to ED came from primary care. So you can see how important it is that primary care GPs and consultants work together. You will see in No More Silos, the call for community is best. That is where people want to be seen wherever they live and whoever they live with, and to value the role of informal carers and family. So the next slide. So what is it about No More Silos that's different? And I think it is, in a way, a complicated way. But if you look at the actions that were mentioned today, 1 to 5 and 8 relate to wider population asks, how will I access services? So we need to take the opportunity now to test some of those actions against patient feedback locally and regionally. What is it that Phone First is doing to increase my access? How will an urgent care centre or discharge improve my access? Questions like that. So we need a call for awareness, information and communication. We've got to improve health literacy. So because some of the jargon, some of the descriptors, how things are described can sometimes be harder to understand. What is anticipatory care? What does it mean? How do I understand what it is? Particularly in the Western Trust, there has to be a health warning on rurality and equality impact. What is the equality impact and the rural impact of some of the things that are there? And I think the voice of service users and carers is absolutely important in this one, and a high impact on mental health. Will my accessing mental health improve as a result of this process? The other actions that you heard about earlier were about how then will I receive care in my own home. Actions 6, 7, 9 and 10. Now this one for me means that we have to give a dedicated focus on the direct voice of service users and carers in their own home and the voice of individuals in care homes, and you've heard about the importance of that. So in that sense, it's very important that we do, in a way now, test what you're hearing probably for the first time today, match that now to what you're already hearing about service users and carers, and to test some of that with groups, with voluntary sector, with wider stakeholders. And my experience is that I have been well heard. I have been asked to get involved as needed, and I have been listened to, but I do think we now need a more critical mass of service users and carers influencing the Western Trust and how the Western Trust wishes to go about things. So thank you.
Thank you so much for your presentation, and I suppose for the work you've done representing service users and carers at a regional level and locally here as well too. And I'm sure we'll hear the opportunities that are presented within the Western Trust when Brona gives us an update on the implementation of our involvement plan for No More Silos. But just before we do that, we had agreed that we would take a few questions from people. We had spoke about 5, but I'm going to do a facilitator's call here and say we'll take it down to 3, just monitoring time, because the chat box has been very active and a lot of answers have come to the questions anyway. So I'm going to hand over to Martin McCrory, part of our involvement team. Martin, is there any questions directed to any of the speakers today that you would want to cover?
Yes, Seamus, we've been able to theme some of the comments coming through into sort of 3 general questions. The first question is for Workstream 1 for Tim and Kieran. There's quite a few comments coming in around access. Does this mean wherever you are in the trust, you will have access to the same services? So that's for Tim and Kieran for Workstream 1.
Where possible, that will be the case. The acute medicine teams and the ambulatory units that work on the different hospital sites will have slightly different ways of working, but really with trying to achieve the same goal. I suppose one limit to that may be that Altnagelvin, as a bigger hospital, has the benefit of having perhaps a few more specialist teams on site compared to the SWA. So we'll have to work within those limitations. But the aim in terms of avoiding keeping ED for emergencies and having pathways the GPs can use to get direct to a specialty will be the same in both areas.
That's great, thank you. The next question is aimed at Workstream 3, so for Bernie and Dr. Monica Monaghan, and it's about the anticipatory care part. It's just a lot of comments coming in around the language being quite confusing for someone who isn't working or involved in this process. Is there a way of changing this language, or have you given consideration to changing the terminology, particularly the name of the workstream? It might help for the public to better understand the work.
Yeah, absolutely. I think when we finish the pilot project and we hopefully move forward, then we should be acute care at home across the trust.
Great. And just one more question for that. Is there a difference between anticipatory care plan and advanced care plan?
Well, anticipatory care, you can, we think very much about advanced, what does a patient want, where do they want it, and when it comes to end of life, we think about advanced directives and palliative care pathways involving the patient where we can, and if they're competent, the carer, the care home and the GP. But we also think about anticipatory care much broader than that. So that can be confusing because anticipatory care can be way beyond just end of life. So that's something that we might have to work a little bit around the language.
Great, thank you very much. And the last question, Anne, is directed towards yourself as the service user and carer representative. There are quite a few comments coming in around the opportunity for more vulnerable groups to be involved, such as older people, people with disabilities, etc. What is your view on how the Trust can ensure these groups are involved in this process?
I think it's important that we work through Brona and her team, and they should know, I would like to think they would know who are the key stakeholders in their area. And in many ways, it really is about making a specific, deliberative approach to involve people in that work. This doesn't happen easily. Involvement isn't easy. Involvement isn't soft stuff. It is hard stuff, it is hard work, but it is really worth the effort to hear those voices. So it really is about scoping out where the voices are, how do you bring them in, how do you support them, and how do you enable them? And I'm very conscious about the health literacy point, about language and how it's being described. A lot of work has to go in to explain. It's about where do I get services, how do I access them, how do I receive them? It's about maybe speaking in a language and having communication messages that help bring people in, because when you do get them in, they stay and they really do give you valuable insights, because there's nothing as important as how a patient has actually received and experienced the service. And we've got to get better at bringing in deliberative, patient-focused feedback into the decisions that we're making. But it is a job of work, and Brona and her team need to be supported in work that needs to be done.
Thanks, Anne.
Okay, that's brilliant. Thanks a lot. It's three questions, and Martin, it's almost as if you planned it. It's a nice wee segue now straight onto Brona for to give an update now in terms of the Western Trust involvement plan for No More Silos. So Brona, over to yourself.
Thank you, Seamus. So the following slide is an extract from our current Western Trust No More Silos involvement plan. And so the involvement plan is a strategic overview of what we want to do in terms of ensuring that we have a service user care and the public's voice embedded throughout the No More Silos work. So this, I suppose, is just our timeline, and we really looked at involvement within a sort of 6-phased approach. And the first phase, I suppose, was us as an involvement team really getting to understand the work that was happening. And it's such a fast-paced piece of work, and people have such a wide remit that it was, I suppose, it was a piece of work looking at how do we develop the involvement and integrate the involvement within that. And I have to say thanks to the local implementation group for really kind of moving along with us and trusting us to bring this involvement piece forward, because we have moved quite fast on it. So at the minute, in terms of phase 1, we have we do have representation at a regional level. So in terms of the department, I sit on the No More Silos co-production group regionally, which is alongside our other trust partners, the department, and then service user care representatives. And that's a really good platform for us to work together, to share learning, and also look at pieces regionally that we can engage the public on, rather than working in our own kind of silos within our own trust. So really worthwhile having that regional approach. And then locally, we've embedded ourselves alongside our current service user care reps, Dinah and Anne, who've been doing great work to date in terms of being a part of the local implementation group, as well as the 4 different work streams. So at the minute we are on phase 2, which you are attending now, which is the public engagement webinar. And really this is about putting No More Silos out there, starting the conversation within the public, generating a bit of interest, raising awareness. And I know that, you know, trying to cram all of this information into 1 hour is not going to get the public fully aware of the No More Silos work, but it's certainly starting the discussion. And I mean, we've had 108 people that have come back to us, and quite a broad number of them had said yes to being involved further, which is great for us in terms of taking the work forward. We will be doing more seminars or webinars, and we'll also be working alongside the department, who are carrying out a number of workshops, more specifically different themes around the 10 action points of No More Silos. So we'll keep you informed of that as well. Once after today, we come together and look at the people who have put forward to become more involved. We'll then move on to phase 3. So in March, we're going to look at creating that bank of service users and carers. And really the purpose around this is about getting people to participate in a more sort of, I suppose, structured and more localized engagement in terms of different themes that we have coming along as the work throughout No More Silos begins to unfold. As part of that, then those service users and carers will help us to develop a recruitment process, to develop a role description for service users and carers that will form the basis of a reference group. And that group will then meet monthly. That group will have monthly feedback from the different work streams, and really it would be about myself and Martin within the involvement team ensuring that those service users and carers have the skills and the appropriate training in terms of understanding No More Silos, in terms of understanding PPI and involvement, etc., to actually fully participate in a meaningful way. Once we have that, we move on to phase 5 then, which will be actually integrating individual service users and carers into the actual work streams so that they can make a meaningful contribution alongside our colleagues within the trust in terms of taking the work forward within No More Silos. And then our last phase, which certainly won't be our last phase, but our last phase of this piece of work will be to participate in the regional rollout of the No More Silos consultation alongside our department colleagues. So that's kind of it in a nutshell, I suppose. And I suppose we really look forward to taking this away now and looking at the people who have expressed an interest in getting involved and setting up another meeting to take that forward. You'll remember when you registered that we did a poll, and we asked 3 pre-questions. We've now just done another poll, which will take no more than 30 seconds of your time, if you could just bear with us. Neil's going to put the poll up on the screen, and we're just asking you just to answer the 3 questions again. Neil, if you want to just put it up there. So if you just remember to scroll down to the bottom, there's 3 questions, and it's basically just the same as before. And then just hit submit. And then back over to yourself again, Seamus.
Yeah, thank you, Brona. We'll just give it a couple of seconds here for people to make their choices. As I say, you would have made a choice whenever you were registering through Eventbrite. So it just gives us an opportunity as well to look and review how this event went in terms of our plan and moving forward as well. So I don't know if we can put up the scores, Neil, can we, from the result? So there we go. So I suppose after today, and look, in terms of the report, we'll send out a measurement of what people's score was beforehand and afterwards, so we can actually measure if it was worthwhile. So obviously, look, there's a lot of people who've said there's some are great knowledge of the work around Northern Ireland. Again, you know, look, we've over 77% with some are great knowledge in terms of No More Silos in the Western Trust. And again, look, there seems to be the majority as well too, in terms of they know about the opportunities to be involved as well too in No More Silos, and really difficult to try and get that information out for the hour. And we'll be interested to hear from those as well too that have little or no knowledge in terms of how we can improve it. But again, it's one of those ones, stick with us. We were never going to try and get everything out today in this 1 hour. And as you can see there's a full process of us moving us right through the year, where we're going to try our best to involve service users and really commit, I suppose, to that vision that Anne O'Reilly presented to us as well too, in terms of having that cohort of people supporting us. So look, I've done the best I can to do it in an hour. I may have went 2 or 3 minutes over, Teresa, but we'll not fall out between friends in 2 or 3 minutes. I'm sure I'll hand it over to yourself just for the final summary and close.
Thanks very much, Seamus. Look, it just falls to me to say thank you very much to everybody who's contributed today to the webinar. I mean, I saw it go up to 92 people there. So that, I mean, that was all we really couldn't have expected any more than that. And I really want to say a very sincere thanks to everyone who gave their time today. I don't intend to stretch it out other than to say we're on a journey here of creating partnerships with No More Silos, with the patient and the client and our population at the end, and giving better services to them. Service users, carers and their families are part of that partnership. And from the trust perspective and from those that have contributed today, it's really critically important that we gather in experience of services and what people want and what matters to them, and how we shape these services. So I hope that this is the start of that process on No More Silos. And I hope that it shows the commitment of the trust to this work ahead. And certainly the team here are really energised about the work ahead. And we look forward to the discussion at the next project board about how the webinar has gone and all of the next steps that Brona has described today. So let's leave it at that, everybody. I hope you will continue to engage with us in the ways that we offer to you. And if there's anything new or fresh that we can do that you think will help, we'd really like to hear from you on that. So please don't hesitate to let Seamus, Brona, Martin or other members of the team know. There will be ways to contact them, which they'll be sending out as part of the follow-up to today's event. So thank you very much, everyone, and enjoy the rest of your afternoon. Goodbye.
Bye-bye.